Now that you have reviewed all the effects of muscarinic receptors when we stimulate them, or also all the nicotinic receptors, we really are ready to put the drugs. And we're going to start with direct-acting muscarinic agonists. They're also known as direct-acting cholinomimetics, being that they're going to mimic the effect of acetylcholine on effector cells. So, over the years with Kaplan Medical, we've managed to narrow down the number of drugs that you should really familiarize yourself with. I'm certainly not telling you, if you know more than this, to trash the drugs you know and you don't see in our book. To the contrary, the more you know, the happier I feel about your basis in pharmacology. But what I'm saying here is, for example, for muscarinic agonist, if you know the drugs bethanechol, methacholine, and pilocarpine, you have the three primary muscarinic agonists that are classically used in US med schools and on the exam to test you on the idea of stimulating these receptors. Now, of course, never underestimate on a board question the use of the endogenous ligand, acetylcholine itself, and its effect on these receptors. But overall, bethanechol, methacholine, pilocarpine are all muscarinic agonists, and as such should mimic all the effect in the table. So maybe you can tell me, what do you think all these drugs would be doing to secretions? I hope you're telling me they would increase secretions. Hey, imagine today I have asthma, I'm wheezing, or I'm a heavy smoker. Any problem with using the drug bethanechol? Of course, not only I've increased the secretions in the lungs, I'm also causing bronchospasm. You remember how it was bad for COPD, those drugs. What would every single of these drugs be board tested for when it comes to the heart? Yes, they would decrease the heart rate. And which receptor would they be using? An M2 receptor, which is GI coupled, that would lower cyclic AMP and SA and AV node. Those bradycardias, never forget that they could result at higher doses in an AV blockade, which would potentially lead to a life-threatening arrhythmia. So you may want to monitor sometimes EKG, worry about cardiac background in your patient. All these drugs would be associated with constipation and urinary retention, or diarrhea and urinary incontinence. If you've chosen diarrhea and urinary incontinence, you are absolutely correct. Look, the message is, if I show you back this big table that we went through, every single of these responses that were mediated by muscarinic receptors will be covered by these drugs. So overall, you now have 3 examples to match to the table. Well, if you want, let's look a little bit at some of the real clinical uses of such drugs. Acetylcholine itself, which is metabolized by the enzyme acetylcholinesterase extremely rapidly, has too short of a half-life to really have any clinical uses. So only expect acetylcholine to be used in problems, particularly in the problems with tracings that we'll see at the end of this unit. Bethanechol, on the other hand, is a muscarinic agonist that is used systemically. Rx for treatment, it is actually used in paralytic ileus. Recall that paralytic ileus is when the patient's gut is simply not moving, and that lack of motility is classically observed post-operatively simply as a consequence of the anesthesia when you use powerful CNS depressants. They tend to also depress the peripheral nervous activity and as such shut down the peristalsis. Remember, one of the major issues to move our patients out of the intensive care unit is when they're going to have that bowel movement, or at least some gases, so that everybody's happy and can leave the ICU. Well, if you want to stimulate peristalsis, bethanechol would be a good drug to use. Same, it could be used in neurogenic conditions, particularly a neurogenic bladder, such as you would see within the peripheral neuropathies that diabetics would suffer from, for instance. The key point is that these retentions, whether GI or urinary, they must not be mechanical. Imagine, for instance, someone with a tumor blocking their gut. Would you use a drug that increased peristalsis and increased motility to the point of spasm if there was mechanical blockage? Of course not. The increased intraluminal pressure could result in increase in size of the gut to the point of bursting, and then your patient would have septicemia. Plus, I think we'd have an awful lot of things to clean around the room also. So with this in mind, make sure you know the uses of bethanical. If I use it for postoperative neurogenic type of ileus or urinary retention, then everything else becomes a side effect. That is, for instance, what would happen to the eye of your patient? Miosis or mydriasis? Say miosis and you keep me happy. Mydriasis, remember, that would be an alpha-1 agonist or a muscarinic blocker, not a muscarinic agonist. Miosis from sphincter muscle contraction. How about effect on accommodation? Are you expecting a spasm of accommodation or a paralysis of accommodation? If you're thinking of a spasm of accommodation with focusing for near vision, you are perfectly on good track to answer the correct point on your board question. Let's not forget that these are drugs that will also increase GI secretion, and as such, peptic ulcer disease patient would not benefit from these medication. Don't forget also that all other secretions are increased: lacrimation, salivation, sweating, and so forth. For methacholine, methacholine actually is really easy to remember because of the choline portion of the name, so it has to be an agonist of acetylcholine type of receptors. As a matter of fact, notice it works both on muscarinic and a little bit nicotinic. It even has a metabolism through acetylcholine esterase, although it's far less than the endogenous agonist acetylcholine. This is not a drug we use for treating anything. It's a drug we use for diagnostic procedures, DX for diagnosis here. And the diagnosing that we want to do is bronchial hyperreactivity. That is an individual who might have very sensitive bronchioles, potentially to allergens. Well, imagine you give a teeny little dose of methacholine to that patient. Certainly not enough to cause bronchospasm. As a matter of fact, you'd give it to a non-asthmatic, someone who does not have respiratory type of responses to allergies. Probably you would see no effect whatsoever from such small doses. But in someone with bronchial hypersensitivity, it will trigger wheezing. At the doses that are used, it is very unlikely clinically that methacholine would cause any type of side effects. But trust your step 1 exam to use it as a classic direct agonist of muscarinic receptors so that you could expect anything from that table. For pilocarpine, this is a drug that is primarily used topically. And when it's used topically, it's used in particular as eye drops to treat glaucoma. We'll do a section on glaucoma towards the end of our ANS review. It's also used for dry mouth, xerostomia. You know, think of something like a Sjogren disease patient. In Sjogren disease, an autoimmune injury is actually causing fibrosis of both lacrimal and salivary glands, causing dry eyes, dry mouth in the young lady. Well, pilocarpine certainly, while we still have glands functional, could help having a little bit of spit and a little bit of tears. Not too bad, huh? Unless you don't want to cry. Pilocarpine otherwise. I'll give you another big one I like on the exam. Anyone remembers how we do a screening test for cystic fibrosis? If you're remembering the sweat test, it's very good. And now you imagine you're the one trying to collect enough sweat from a cystic fibrosis patient to measure the increased chloride in that sweat. Come on, unless you live in South Florida, there's no way you're going to get a gallon of sweat in 1 minute. So obviously, what are we going to use? We're going to use a drug like pilocarpine, a muscarinic agonist, to increase sweating, and then we'll be able to measure the actual increased chloride due to that CFTR being defective secondary to a mutation. So just to give you some idea of what these drugs could be used for on your exam. And really overall, there's only one last thing I would like you to think about. If these drugs were used systemically, and if they are so on your exam, should you expect a direct-acting muscarinic agonist to have any effect on the blood vessel? Well, if you recall, there are muscarinic receptors on the endothelium of the vasculature, but they're not innervated. If you're a direct-acting drug, you don't need innervation to do your effect. All you need is the receptor. So yes, they will bind to the endothelial receptor, and the response will be vasodilation through the actual nitric oxide release. Well, if those are muscarinic agonists that are direct-acting, you know, the next group of drugs we're going to have to contrast will be the indirect acting cholinomimetic. Indirect acting because they do not work on receptors, but rather work on the acetylcholinesterase, the enzyme that is actually in the synapse to degrade acetylcholine. In a nutshell, let me show you as a little diagram. This is your nerve terminal, and it's about to release acetylcholine. All this in order to work on either muscarinic or nicotinic receptors. The enzyme acetylcholinesterase is the enzyme that will catabolize acetylcholine and terminate its action. My drug in purple right there is blocking acetylcholinesterase. Therefore, its job is to increase levels of acetylcholine in the synapse, indirectly to cause stimulation of muscarinic receptors and nicotinic receptors. So is it fair to think that an acetylcholinesterase inhibitor is going to be, at least for one half of its pharmacology, identical to bethanechol, methacholine, or pilocarpine? Of course, there's only one thing that an acetylcholinesterase inhibitor will not be able to reach when it comes to muscarinic response. It's the blood vessels, because the receptors were not innervated. So really, it would be a pharmacology which is like bethanechol, except for the vessel. So we'll put this here together. So what we're going to have to really work on, obviously, with these drugs is the key difference they have over the bethanechol family. The fact that they will also cause stimulation of nicotinic receptors, and that is something that was not shared with the previous drugs. Now, the way we're going to use these drugs, because we don't want to overstimulate the receptors, we are more likely to use these drugs to try and reverse a blockade of the actual receptors themselves. Look, imagine that you have somewhere an antagonist, a blocker of nicotinic receptors. Then raising acetylcholine in the synapse is possibly going to cause that blocker to be removed from the receptor. Replacing it with acetylcholine would reinstate the nicotinic responses. Other possibility, you have not a nicotinic, but a muscarinic antagonist. And if you have a blocker of muscarinic receptors, providing again it's a competitive antagonist, then once again increasing acetylcholine will kick this blocker off the receptor. Expect to find this as we walk through that PowerPoint slide and we see the uses of the main acetylcholinesterase inhibitors. So let's go into that table. And notice, unfortunately, we could not narrow it down to 2 or 3 drugs. Here you have a bunch of them, and you should really know every single one of them carefully. I'm going to start with edrophonium, the one at the top. Edrophonium, one of the things you'll never invent because we're not chemists, is how long it's going to work for. It is an ultra short-acting acetylcholinesterase inhibitor. And if it's short-acting, forget about using it for treating anything. We'd have to keep on giving the drug over and over again the whole day long. So we only use it for diagnostic procedure. And a key point to use it for, that's my first high-yield point of this slide, the treatment of myasthenia. Now remember, myasthenia is another of these autoimmune diseases. It's an autoimmune disease that affects the skeletal muscle. In this disease, autoantibodies are actually blocking competitively the nicotinic acetylcholine receptors of the skeletal muscle. So what happens to your patient? You remember how she develops some facial weakness, some ptosis, and of course all that weakness comes from slowly a paralysis of skeletal muscle simply because of lack of stimulation. If I'm using an acetylcholinesterase inhibitor, as we saw in the previous diagram we built together, I'm going to kick these antibodies off the receptor. And as I do so, the muscle tone of this patient should improve. If I see an improvement of muscle tone when I use edrophonium as a test, then I have diagnosed myasthenia gravis. And when I diagnose myasthenia gravis with edrophonium, now I'm ready to treat it, but I need a longer acting drug. You're going to go with me then to the drug neostigmine. Neostigmine is another acetylcholinesterase inhibitor, but this one is long-acting. And as a long-acting drug, it is used not for diagnosis, but for the treatment of myasthenia. So now you know the diagnostic test with hydrophonium. By the way, we call it in internal medicine the tensilon test, and tensilon is the trade name for hydrophonium. But recall that we don't use trade names not to do advertising on the exam, so know it well as hydrophonium. And now you also know the treatment, the main treatment being the drug neostigmine. So you send your patient home with neostigmine. And then maybe a couple to 3 days later, she comes back again with flaccid paralysis. Now your big issue would be, did I give enough neostigmine? Maybe I should give more. Maybe she still has myasthenia. Or did I give too much, and because of the excess acetylcholine, I got desensitization of the nicotinic receptors. You remember how nicotinic receptors desensitize rapidly? Well, if they did, now we would end up having skeletal muscle paralysis all over again, but because of desensitization. If you look back at hydrophonium, hydrophonium is also used to differentiate myasthenia from cholinergic crisis. And what I want you to understand here is that the terminology cholinergic crisis, it means desensitized receptors. It happens when you had too much neostigmine. So let's try it. I have this patient with muscle weakness. I give her the hydrophonium. The muscle tone does not improve. If it doesn't improve, is it myasthenia or is it cholinergic crisis? If it doesn't improve, it's a cholinergic crisis. I must remove neostigmine. Hey, next thing I know is that instead of the muscles of the face or of the limbs being weak, what if it became the diaphragm muscle? Then this patient would stop breathing, and unless they were mechanically ventilated, they would die of the cholinergic crisis. So it's important to make the distinction. It gives you two major uses to the drug hydrophonium: the diagnosis of myasthenia and the differential diagnosis between myasthenia and a cholinergic crisis. Well, that's the first point. I'm hoping that all of you understood. And now we're going to look at a second point that is classic on the exam. We're going to look at the drug physostigmine. And as we look at the drug physostigmine, you may want to highlight, well, it's a tertiary amine. And by the same token, you glance at the bottom and realize neostigmine is a quaternary amine. What on earth are we talking about? This is pure chemistry, but you're going to want to know this for your general principles. This is a nitrogen, and nitrogens classically make 3 bonds with other atoms. So imagine one of them has God knows what side chain, so I'm going to call it R, and let's say that the other 2 are just some H's. I would call this R and H2, and just count the valences. There's 1, 2, 3. I call that a tertiary amine. And a tertiary amine, notice, has no pluses, no minuses, therefore it's unionized. Well, now you finish the sentence for me. If it's unionized, is it water or lipid soluble? I can hear you from here. Everyone is saying lipid soluble. If you're not, slap yourself. Lipid solubility is indeed the answer, and with lipid solubility, it means it will be well absorbed, well distributed, and it will go to the brain. If you raise acetylcholine in the brain, now you're going beyond the autonomic nervous system. You are also getting stimulation from a major neurotransmitter in nervous tissue. Contrast now. I'm going to add 1 extra valence. I'm putting an extra H. When I do that, I'm actually going to render this positively charged, and this becomes RNH3+. When it becomes RNH3+, you now count 1, 2, 3, 4 valences around the nitrogen. That is what you call a quaternary amine. And when you call that a quaternary amine, no doubt it is ionized. If it's ionized, it's water soluble. If it's water soluble, it cannot cross the blood-brain barrier. Therefore, it will not get into brain tissue. Well, now you know the ins and outs of tertiary and quaternary amine. And as I go back to the slide, physostigmine is a tertiary amine. As such, it will enter the CNS. If it enters the CNS, we're going to use it as an antidote in atropine overdose. This is the second point in this portion of the chapter you must know well clinically. Atropine is a muscarinic antagonist. As a muscarinic antagonist, I'll kick it off its receptor by raising acetylcholine through inhibition of its metabolism. But atropine is also a lipid-soluble drug. It will cause toxicity in the brain. And if it does, when I reverse the effects of atropine in overdose, I must use an acetylcholinesterase inhibitor that can't cross the blood-brain barrier. I need physostigmine and not neostigmine because it's a tertiary amine. Like this, it will get into the CNS. Don't worry about the glaucoma. We'll talk more about this later. Well, let's go to our third point. For the third point, we're going to look more at neostigmine, also its cousin, pyridostigmine. These are quaternary amine. You now understand the statement there is no CNS entry. It's an ionized drug. And the third point is right here. The idea that we're going to use this to reverse the non-depolarizing neuromuscular blockers. Well, what are non-depolarizing neuromuscular blockers? Well, just to put it in perspective, they are the drugs that we like to refer to as curare-like drugs. You know, these are nicotinic receptors antagonists that we use prior to surgery or prior to intubation in emergency or operating room to trigger flaccid paralysis in the patient. They're competitive blockers, so just like the antibodies of myasthenia, I can kick them off the receptor and reverse the neuromuscular blockade with drugs like neostigmine or pyridostigmine. Why wouldn't I want to use physostigmine? Well, I'm sure you guessed. We don't have skeletal muscles in the brain, or so I hope, and therefore there is no need to raise acetylcholine to kick a blocker off skeletal muscle in our CNS. So we want quaternary amines to reverse the neuromuscular blockade of non-depolarizing drugs such as curare. As to the ileus and urinary retention, well, make the link with bethanical type of drug. This is by raising levels of acetylcholine at the level of GI and GU tract muscarinic receptors. These are the primary drugs. So let's summarize 3 things you must know about acetylcholinesterase inhibitor. Edrophonium for diagnosis of myasthenia and differential, of course, with cholinergic crisis. Physostigmine as the best drug in antimuscarinic overdose, particularly atropine. And neostigmine, pyridostigmine, not only in the treatment of myasthenia, but also in the reversal of neuromuscular blockade by curare-like drug. Don't forget that taking too much of any of these drugs would result in a cholinergic crisis. How about trying to raise the CNS acetylcholine levels? Well, we may want to do this for a disease that I'm approaching very readily right now, which is Alzheimer's disease. And when you look at Alzheimer's disease, you're looking at a pathology for which we have plaques of amyloid. You remember the beta amyloid, which is produced from a gene that's on chromosome 21. We have neurofibrillary tangle of tau proteins, which are poorly phosphorylated. These plaques and tangles are only relevant pathologically on autopsies, since we find them in the brain areas that are affected in Alzheimer's disease, namely the hippocampus, with affecting the actual memorization in the patient, but also the frontal cortical areas, limbic areas, where importantly we have some effects on moods, on behaviors, and we can explain in part the dementias with association with these findings. None of the drugs that we currently use in Alzheimer's treatment are addressing the point of amyloidosis of the brain, amyloidosis of the vessels with risk of strokes, and the neurofibrillary tangles. So what are our drugs doing to an Alzheimer's disease patient? Well, here's the deal. The neuroanatomist told us that there is a little nucleus in the midbrain which contains acetylcholine that is called Maynard's nucleus. Maynard's nucleus sends output with acetylcholine to both hippocampus and frontal lobe. If those neurons are destroyed by the disease, then the whole idea of the treatment is purely biochemical, and currently the idea is to increase levels of acetylcholine in the brain of our patient. Can I use physostigmine for that? Well, be my guest. The problem is that you would need to have an IV line in place for that patient for the rest of their life, and you would have to deal with lots of side effects because physostigmine is very powerful. So no, rather we want oral formulation of lipid-soluble acetylcholinesterase inhibitors. And the drugs to do that are donepezil and the prototypical tacrin. They are lipid soluble for their CNS entry, and they are purely used in Alzheimer's disease. It does mean that the day you take your board exam, an Alzheimer's disease patient could be treating donepezil in your stem, and then you could be board tested again on all the side effects of these medication, which would have to be all the peripheral effects through the autonomic nervous system of increasing acetylcholine and synapses. On the other hand, you know, if you really want to test yourself on toxicity, well, you might as well do it with the famous organophosphates. Organophosphates, there is hardly a board exam that doesn't test them. Organophosphates are irreversible acetylcholine esterase inhibitors. First point, they're irreversible inhibitors of an enzyme. You know, it means non-competitive. And if they're non-competitive, I should think graphs. And as I think graphs, let me show you how it could sound on your exam. You remember those biochemistry graphs? I'm sure you do, and I'm sure you're sweating already. This would be 1 over acetylcholine, the substrate. This would represent acetylcholine esterase, the enzyme. And here would be 1 over the speed of production of the product, which is choline or acetate. Let's not forget that here on the y-axis where the curve crosses, you see 1 over Vmax. And of course, here on the x-axis, you see minus 1 over Km. Whereas Vmax gives you idea about how many enzymes you have working, Km gives you an idea as to the affinity of such enzymes. So what would I do with a non-competitive inhibitor? If I'm irreversibly binding to the enzyme, do I change the shape of the enzyme, or do I change the number of enzymes that are available for metabolism? Well, what I'm doing with irreversible inhibition is decreasing the number. And if I'm decreasing the number, I'm decreasing Vmax. The speed of metabolism will go slower because I have less enzymes working on acetylcholine. Pretty straightforward. You decrease Vmax. So go from 2 to 1. That's a decrease. Then what would happen to 1 over Vmax? It would go from 1 over 2, which is 0.5, to 1 over 1, which is 1. So if this was 0.5, that would be 1. In which case, no change in affinity, crossing higher, this is where you would put your organophosphates. So if the organophosphates would be there, guess where, of course, would neostigmine family of drugs be? All the other drugs we reviewed so far were competitive inhibitors. Competitive inhibitors do not change Vmax, so they would cross the y-axis at the same spot. What they change is the affinity. They change the shape, therefore they actually decrease the affinity. It would still be a curve that is above the black curve, but this would be the hallmark feature of neostigmine family or competitive inhibitors. You know, many of your predecessors report to us these questions that use graphics of biochemistry. Be aware of them. Work them back out with your biochem book and now start applying them to drugs. Every occasion I have where I know there's been a board question like this, I will share it with you. And if inhibition is always above the black curve, then remember, I'm not going to draw them for clarity, but anything that turns on enzymes would be below that black curve. Well, back to the notes. What is an organophosphate? An organophosphate is primarily an insecticide. And as an insecticide, there are 2 primary examples, malathion, parathion. Now, when you don't want to kill insects, but you want to kill humans, and maybe the human is bugging you, by the way, then you use nerve gases. And nerve gases are insecticides for humans. They work exactly the same way. An example is sarin. You're more likely to see the real insecticide than the nerve gas on your exam. But the key point here is if it's an insecticide, who gets exposed to this? It has to be an occupational exposure in most cases. And the classic story is going to be that of a farmer who uses the insecticides to spray on plants and either has an accident and gets exposed to it, sprays himself or herself, or otherwise tried to commit suicide or was in some kind of murder scheme. Maybe the farmer's wife is in love with the other farmer who lives only about 50 miles away, so decides to get rid of the other farmer. Whatever the case is, farmers are your classic story with organophosphate poisoning. There is an organophosphate we use clinically. It is ecothiopate, and notice fate for organophosphate. And ecothiopate is used as eye drops, certainly not systemically, in glaucoma. There's no doubt we're going to have to review that glaucoma at the end of the section. Many drugs in the section of cholinomimetics are used in glaucoma. It's because they cause miosis and spasm of accommodation. Let's review the toxicity of acetylcholinesterase inhibitors, particularly looking at these organophosphates. Parathion and malathion are prodrugs. They're prodrugs that are inactive. As such, they require metabolism through cytochrome P450s to be turned on, the active form being paraoxon and maloxon. Those prodrugs, they're metabolized extremely slowly in humans, very quickly in insects, meaning the insect will bear the brunt of the active metabolite. It is further known that P450s also break down paraoxon and maloxon into inactive compounds, and that conversion is extremely rapid in humans, extremely slow in insects. So obviously, these acetylcholinesterase inhibitors will be insecticides more than humanicide, if we can say. Now, what they will result in is, with the acute toxicity, excessive muscarinic and excessive nicotinic stimulation. So your exam loves this farmer who gets exposed to too much organophosphate, because they can then test you on all aspects of muscarinic and nicotinic pharmacology. Here we go. With muscarinic effects, you expect for GI-GU tract increased peristalsis and voiding with diarrhea and urination. You have a hallmark feature in your emergency room. Looking at the patient straight in the eye, you'll see pinpoint pupil, miosis, from the sphincter muscle contraction. And you'll have a big worry to deal with, a massive bradycardia with a potential of AV block in this patient. Otherwise, this is a patient who's going to have bronchospasm and increase every single secretion. That bronchospasm and wheezing would be associated also with lacrimation, salivation, and sweating. So as you see this classic picture from muscarinic stimulation, all you have to add is that because we're also increasing acetylcholine in the CNS, we're going to see some significant CNS stimulation. And that is from the standpoint that acetylcholine is excitatory in the CNS. That CNS stimulation could result down the road to the ultimate, which would be to develop seizures. Look, if muscarinic responses are a big part of the presentation of your patient, then you'll be very happy to use a muscarinic antagonist in order to treat those symptoms. And your muscarinic antagonist is going to probably be atropine itself, the prototypical muscarinic blocker. Atropine, on top of this, has this advantage, as we just reviewed, to cross the blood-brain barrier, and in crossing the blood-brain barrier to help us also deal with the CNS excitation. Let's look at the nicotinic effects. Nicotinic effects will involve the skeletal muscle getting excited, so there should be some twitches. There might be actually some fasciculations, and very quickly we know that these receptors can desensitize, so ultimately there should be paralysis. You are basically getting a cholinergic crisis, and as such you know that we are going to have a big issue here, because how am I going to treat a desensitized receptor? Let's think. If I give an agonist to try and restart the muscle, all I can do with the agonist is further desensitize the receptor, since stimulation is what shut down the system. Conversely, if I use an antagonist, if I use a blocker, it's never going to do anything either, being that blockers have no efficacy. So the end point is I should get rid of the drug, but the big problem is it bound irreversibly to the enzyme. So we really have a big limiting toxicity when it comes to the nicotinic effect. By the way, nicotinic receptors are also in the brain and also participate in the CNS stimulation. So management-wise, we need atropine for the muscarinic effect, and we need to figure out a way of regenerating the actual enzyme with a drug that's called pralidoxim. Now, this pralidoxim is a big story because it will allow us to get the enzyme working again. It is often referred to as 2-PAM. And the word regeneration is pretty unique here to use it as an antidote. We are to see that it has to be used very quickly. There is a time-dependent process referred to as aging that would then preclude the use of 2-PAM in our patient. So let's look at the diagram together that allows us to understand the use of 2-PAM. You have both text on the left of the diagram, and you also have a figure on the right of it. First point to highlight, organophosphates are irreversibly acting. It means they make a covalent bond with the enzyme. And as they make a covalent bond with the enzyme, what they do, they phosphate, they phosphorylate. And look what they phosphorylate. They phosphorylate a serine hydroxyl group on acetylcholinesterase. Now that point of molecular effect of the drug is also testable. It's the idea that serines are a great spot, just like threonine, for phosphorylation, for co- or post-translational modification, for instance in biochemistry. And here what the drug merely does is phosphorylate the enzyme acetylcholinesterase. Well, this phosphorylation is initially reversible, between quotes, if I use 2-PAM. But if I wait too long, then aging would settle in and we would no longer be able to reverse it with 2-PAM. So you read it in text. Let's look at the diagram. As we look at the diagram, I'm going to circle for you in red the organophosphate. The organo portion, it's R. The phosphate portion, it's the P. And what we're showing you right there is, I'm painting it in bright red, the actual phosphate bond that is made between the hydroxyl group of serine and the organophosphate. This is the covalent bond that results in us saying this is an irreversibly acting drug. What can I do with this? Add 2-PAM. Let me take a blue pen to show you 2-PAM. As we look at 2-PAM, it is a very reactive compound, and what 2-PAM can do is literally grab the phosphate group that we had painted in red and make that bond with itself. If you want, it's as if the 2-PAM loves the organophosphate more than the enzyme acetylcholinesterase does. So 2-PAM can grab the organophosphate and in that process regenerate the enzyme acetylcholinesterase. As soon as you release the enzyme from its organophosphate, it can now again digest the acetylcholine and reinstate the actual muscle contraction so that you don't have to have a patient who stays on a respirator for the rest of the week or so and then could contract pseudomonas or have a bill that's big enough in the hospital to cause a heart attack. So as I'm looking at this, it depended on one story. For 2-PAM to make that bond, it needed R to be present. R must be there if I want 2-PAM to regenerate the acetylcholinesterase. So let me show you now what aging is. You see aging right here? Aging is a hydrolysis process. Hydrolysis meaning it uses a molecule of water, and what is hydrolyzed is the R group. That hydrolysis of R, you see, there's no R right here. So let me put it, if there's no R right here, now the enzyme is just purely phosphorylated. When it's purely phosphorylated, the phosphate is not reactive enough to bind to 2-PAM. If that's the case, now the reversal is impossible. Aging is the name of this reaction, and we simply call it aging because it's a matter of time. So how long, you're asking? If it's an organophosphate that's an insecticide, 6 to 8 hours. So that's good, providing the farmer doesn't live in the middle of nowhere and needs 12 hours to get to a hospital. Within 6 to 8 hours, we should be able to do it. The big issue would be with nerve gases. When you look at nerve gases like sarin, would you believe that the actual aging is about 2 to 3 minutes? So if someone was spraying people in a subway station, let's say in New York City, unless you'd be walking around with atropine and 2-PAM in your handbag or in your pocket, you probably would have to die asphyxiated. Well, organophosphates, be very careful, do not only cause some board relevant question with their acute toxicity, although that's the more common situation. Don't underestimate the chronic toxicity of constant exposure to low levels of organophosphate. Chronic toxicity has nothing to do with acetylcholinesterase inhibition. What happens is demyelination of nerves. And if it demyelinates nerve, it's going to cause neuropathies. And neuropathies present with sensory, motor type of weaknesses and losses. In a way, chronic toxicity mimics multiple sclerosis. It's like MS. You know as well as I do, we don't have treatments for MS. We don't have treatments for chronic toxicity either. Demyelination not being due to acetylcholinesterase inhibition. Don't you dare answer on your exam, atropine and 2-PAM are the drugs to treat this demyelination. Much rather, what you need to think about there is the fact that anything that you saw previously for the acute toxicity is a distractor. There is no such thing as diarrhea, urination, meiosis, bradycardia, and so forth. In chronic toxicity, multiple sclerosis-like pattern, maybe a foot drop, a wrist drop, scanning speech, diplopia, these type of responses. Why does it demyelinate? Well, let's not forget these are extremely lipid-soluble compounds. And if they're extremely lipid-soluble, they love to go into the myelin sheath. Myelin is itself a lipid to improve the speed of conduction. Like most drugs, they probably behave as haptens, and once bound to a larger structure, trigger an immune response with then destruction of that tissue. Well, this concludes looking at stimulation of muscarinic receptors, either directly or indirectly. So you know what we have to do now. We need to block these receptors.